Prehabilitation is a very interesting and an exciting era in esophageal cancer patients, and has been so for quite a few years now. I think there's no dispute about the benefit of prehabilitation in patients undergoing esophagectomy. There are enough randomized controlled trial studies and even meta-analysis that show that prehabilitation results in a reduction in postoperative complications, mainly postoperative pneumonia, which is a very common complication in our patients, but also results in an overall reduction in post-operative hospital stay and even intensive care unit stay. And that translates to a significant cost savings for hospitals who are treating these patients. However, we all know that a large number of esophageal cancer patients can be considered to be of borderline fitness. And what does borderline fitness mean? Fitness is mainly measured in different ways. It is subjective, where we ask questions in terms of how much they can do. It's called exercise tolerance. Or we have performance status. Or sometimes we surgeons do simple tests like the stair climb test. Those are the subjective tests that we use. But then objectively, we also have tests like the cardiopulmonary exercise testing. With all this testing, we can identify a group of people who are not very fit. But on the other hand, they are also not so poor in terms of fitness that we can't rule out surgery altogether. And this group that we identify we can use different measures for this, but let's just say that the one thing that we all understand is that many of these patients are frail. And frailty, as we all know, is a syndrome that's associated with mainly elderly people, but can also be seen in younger people now, especially those who are obese, who are sedentary for a long time. And frailty is associated with things like slow walking speed, weight loss, etc. And we see a lot of this in our patients. So if you look at the research in terms of the effectiveness of prehabilitation in frail patients, the research is actually very positive. That even in frail patients, we can see the benefits of prehabilitation in terms of post-operative outcomes and hospital stay. So there are different ways to assess people's borderline fitness. Some of them are clinic-based, where we ask patients questions on exercise tolerance. We ask them how far they can walk before they have to stop or they get breathless. We can use a stair climb test that people use in their clinic. But there are more objective tests, such as the cardiopulmonary exercise testing, which in many ways is considered to be the gold standard in terms of assessing preoperative fitness, but it's expensive, it's not easily available and accessible. As a result of which, there are other tests that can be applied within a clinic setting, and that one of the most common ones is a 6-minute walk test. And so the 6-minute walk test is the one that is most commonly used in most prehabilitation programs to select those people who are considered to have the poorest functional capacity, or let's say fitness, and our programs are mainly directed towards them. Now, obviously, exercise is an extremely important aspect of prehabilitation programs, but that's because we want to improve their fitness and their functional capacity. And by doing so, we can not only improve the outcomes, such as postoperative complications and hospital stay, but we can also make these people more eligible for curative pathway instead of depriving them of curative surgery. So exercise is important, and exercise has to be highly personalized, because many of these patients are elderly, they haven't exercised for a long time, they're facing severe symptoms. Many of our patients are on neoadjuvant chemotherapy, because of which they will experience side effects. But exercise cannot be seen just in isolation. Exercise has to be seen as part of a multimodal approach in our patients. So many of our patients will have dysphagia, they'll have weight loss, and so the focus on nutrition is extremely important. And many of these patients will also have significant psychological morbidity, for example, anxiety, distress, depression. And unless we address these psychological factors, it'll be very difficult to make patients adhere to the exercise program. So all these programs have to be multimodal, and you also have to then also think about other factors that impact on post-op outcomes, such as anemia, such as smoking, alcohol intake, and all this can be bundled together within a multimodal prehabilitation program. We are still at a very early stage in terms of the research, evidence of prehabilitation in terms of long term outcomes and especially survival. It just seems logical that if there are a group of people who are being denied curative surgery based on their fitness for surgery, that if we make them fit, there is a higher chance that they will access that surgery and thus they will be able to at least have a chance at cure of esophageal cancer. But we don't have the evidence as yet in terms of prehabilitation influencing survival. But prehabilitation obviously also works in different ways, which is interesting. There is emerging evidence that prehabilitation, because of its impact on people's overall health, results in better completion of neoadjuvant treatment. So, our own research study, as well as others done by our colleagues in the UK, have shown that prehabilitation group patients have a higher chance of completing neoadjuvant treatment as planned rather than the neoadjuvant treatment stopping prematurely. And that obviously will have a survival benefit because you can then complete the gold standard treatment that you were intended to have. In other settings, prehabilitation has also been found to improve access to adjuvant chemotherapy in people who had surgery because they have a lower risk of post-op complications and thus a lower risk of post-operative health deterioration, and thus they can start their adjuvant chemotherapy on time. But what there is enough evidence on is that prehabilitation definitely improves patient-reported health-related quality of life throughout the cancer pathway, both during neoadjuvant treatment and even after surgery. There's research that shows that patients who undergo prehabilitation report much better quality of life at the end of surgery, and the anticipated deterioration that we see in quality of life, especially physical function in our patients, is not so much in patients who've undergone prehabilitation.